and welcome to Willow Lifeline Dialogues, to our Code of Life series where we unravel the science behind our DNA and the deeply human stories it holds. I'm Dr. Mercy Korir, your host through these life affirming conversations where medicine, hope, and resilience come together. And in this episode, we bring you the story of Lucy Mwaura. Lucy was told that her newborn child may not live past her first birthday. Imagine facing this through the hospital corridors, medical terms you can barely understand, and sleepless nights filled with tubes, seizures, and silence. This was Lucy Mwaura's world. Here is her story.
In genetics, sometimes it's not what you see, but what is missing. A tiny missing piece of DNA, microdeletion, can alter the course of life forever. This is the story of Lucy Mwaura and her daughter Cindy.
My name is Lucy Wanjiku Mwaura. I'm from Kiambu County, Githurai sub-county, a mother of a girl called Cindy Nyamburanganga, who had a rare disease.
The journey began long before Cindy's birth in the quiet weeks of pregnancy, when Lucy's excitement was shadowed by the first signs of concern.
So the first trimester, it was normal, but about the nausea, the normal signs of pregnancy, they were there. But now after going for the clinic after 24 weeks, that is the time that the gynecologist noticed there is mass of water in the brain, and they needed to do a scan, and they talked of the child was hydrocephalus. So I was given a referral to Kenyatta, and they talked of they were unable to do anything until the child was to be born, so that they can have shunt on her.
Like most parents, Lucy hoped doctors could explain why her baby was different and had desperately hoped for a cure. Cindy faced a storm of health challenges. Some, like hydrocephalus, fluid in the brain, began even before birth. Others appeared in everyday struggles like feeding, just a few drops at a time, reflux so severe it needed surgery, or constant infections, seizures, and slow growth. It became a journey of endless hospital visits and fragile hope.
She started having convulsions, vigorous convulsions, and this made me to take her back to the hospital, where she was admitted again for almost 2 months, of which we managed to control the convulsions, but she had pneumonia, which made her not to breathe well, and she was under oxygen. And we stayed there until we were to buy an oxygen cylinder. But God is faithful. She managed to breathe, and we were discharged again after she was 4 months.
But even with all these interventions, there were still questions doctors couldn't answer. The mystery went deeper into Cindy's DNA.
That is the time they requested me to have a genetic test done, of which after now trying to inquire how much we can use, I felt it was too much for me, and by that time we did not have any insurance to pay for us. So that one neatly paused. Let me say, hiyo, even after being told by the doctor, mimi kwangu kwa pesa nikaona not then. So and then after now for duplication kufanywa, because of the infection, the same doctor, the primary doctor, akanikumbusha, there was a time I had told you to do. Will you do it? Now we see what is wrong with them. So that is the time Dr. Mutinda came in And the genetic test was done, and we found that the chromosome 16 doubled, and it affected the brain. And there was deletion of the part of the brain was not formed.
Tests showed a problem with Cindy's chromosome 16. A tiny piece was missing and another was repeated. That disruption affected how her brain formed and how her body functioned.
That time, Dr. Mutinda came with the counselor, and they made me to understand this was a condition. It was not a disease. It was a condition, and we are supposed to manage it, not to treat it. So through now the counseling and the explanation of how the genetics or the chromosome had affected the brain, I came to understand I'm not waiting or I'm not expecting Cindy to be treated or to heal. We are managing her condition. It was hard to start with, it was hard. But later, it came to my senses. Whatever I'm having, it is not a dream. It is real. And I'll have to take it and carry on. And it helped me.
Lucy couldn't face the thought of losing her baby. Denial sometimes felt like the only way to keep going, a feeling many parents of seriously ill children will recognize.
We had a family meeting with the doctors and us, and they talked of, after assessing the child, they talked of those children with those now syndromes. They were, if they celebrated their first birthday, ilikuwa 50-50. So to me, nilikuwa naona every day ikipita, unaona maybe ataenda kesho. So myself, initially sikuwa nataka kujua more anything to do with genetic, because I knew after knowing si ataenda tu. But now niliona after the first birthday, ameruka na tumeendelea, now that started motivating me.
Parental guilt is a heavy burden in the world of rare diseases. Parents often ask themselves what they could have done differently.
Sometimes I usually blame myself, lakini nafika mahali najiambia I did my best. Because even carrying all these, nilijaribu. Hata mtoto mwenyewe alijaribu pia.
Behind every child with a microdeletion syndrome is a family carrying heavy loads, mountains of bills, countless clinic visits, endless hours of therapy, and the quiet hope of finding someone gentle enough to take care of their child, all while wrestling with the constant thought of giving up.
To raise her, it was expensive. Plus, every week, we were supposed to take her 2 times on Tuesday and Thursday for therapy. Lakini ilifika mahali nikaambia daktari, it is exhausting, plus it is draining me. Request tukimpeleka on a Thursday. So every Thursday we would go for therapy, not counting the times we are going for clinics. And it was not only one clinic. This time for you are going for gastro clinic. This time you are going for neurosurgeon. This time you are going for the macho. So it was hectic.
Her breaking point came when no nanny lasted more than 2 days. Cindy's care, tube feeding, constant monitoring, and fragile health was too overwhelming for most.
So nannies, it was hectic. Hiyo ilinikula kichwa mpaka mimi mwenyewe nikaamua itafika mahali niache kazi. The father was always there, always, even now he's always there. So angesaidia kwenye ataweza. So my sister-in-law, my brother, but I don't have a mom. So kuna wakati ingefika nijiulize, I wish I had my mom here. Because wakati mwingine labda angekuja ananisaidia, at least nalala kidogo. But even them, that like that my sister-in-law alikuja kwa show ya my mom and she tried. So naweza sema the neighbors, they were ever supportive.
Conditions like DeGeorge, Williams, or Prader-Willi each look different, but all begin with the same thing, a tiny missing piece of DNA. Cindy passed away on January 10, 2025 after an infection. But her parents, Lucy and Benson, found the courage to face the future with strength, pursuing genetic testing and keeping alive their dream of another child.
We buried her on 13th January. So from there, we decided to take a step to know whether maybe one of us is having a problem. So we went back to Dr. Mutinda and akatutuma for tests. The tests were done, and after the results were very positive. So we are waiting.
Lucy believes government support is critical. Subsidized therapy, affordable drugs, and stronger systems of care could make the difference between despair and resilience for family like hers.
Others with the rare disease children, number one, they're supposed to love their children. Number two, they accept their conditions. Because if they have the denial, they cannot be able to take care of the child. Number three is if they can get support from other people, because most of the ladies with these rare disease children, they go down because of they don't have any person to talk to help them, because like this journey, it is expensive. So you require financial assistance, you require psychological assistance, emotional as well. But the first thing is accepting the condition. That is the way that your child is. You can't change that condition. You just accept and you carry on. But I'll also talk of the government too. They're supposed to be supportive. Because, for example, for therapy, I wish we can have hospitals where you can go and they do that therapy free. Because like Kenyatta, every therapy session, 1,200. And you are required to have 2. Like myself, I was supposed to have 2. There's others, they'll even have 3 days per week. So it is draining. Bearing in mind that you have to feed the child, you have to have transport. So I think the government can come in. And also, for their medication, it is also so expensive. You'll find that like Cindy was using 4 types of drugs every day.
It was only after losing her daughter that Lucy walked into a Rare Disorders Kenya meeting. There she saw something she had never imagined: grown men and women living with rare disorders. In that moment, she couldn't help but wonder how different life might have been if her daughter had lived long enough to join them.
So I came to go to attend their session, some of their session this year after the death of my child. So I've attended one gathering. We had gone to Gertrude's. So that is where they had met, and so many people came, and we had so many children, and also not children, even grown up with these rare diseases, and they are managing them. And I was so encouraged to have a rare disease lady who is a doctor, and she's on wheelchair. So these rare disease victims, sio lazima waende before they mature. So huyo alinitia moyo mpaka nikaja so mpaka nikaanza I wish hata wangu wangefika pale, but nikasema all in all ni sawa tu.
Lucy's journey doesn't end in silence. It begins a conversation. By sharing Cindy's story, she's helping others see that rare conditions aren't invisible and that understanding can open doors for families everywhere. For Code of Life, I am Sarah Kamande.
From that deeply emotional story, we journey through the science of microdeletion syndromes, which is what that story is. A group of rare genetic conditions caused by tiny missing pieces of DNA. They're invisible to the eye, yet life altering in their effects. To help us make sense of it all is Dr. Catherine Mutinda. She's a pediatrician and geneticist who works closely with families across Kenya to understand these inherited conditions, children's developmental challenges, and the tough choices that sometimes comes with knowing more about our genes. Dr. Karibu, and thank you for always honoring our invite to come and speak and, try and understand these very complex things that manifest so openly in our day-to-day life. So we've heard and seen Lucy's story. In simple terms, how do you explain what microdeletion syndrome is?
Wow, it's so hard to call her Lucy. I call her Mama Cindy, so just allow me to refer to her as Mama Cindy.
That's okay.
So microdeletion, small erasure. Something has been erased, a small erasure. Something small has been erased.
Literally deleted.
Deleted. When people ask me what do I do, like you tell somebody I'm a heart doctor, I take care of the heart. So I'm a cardiologist. So when I say I'm a geneticist, I take care of this organ called the chromosome. And the chromosome has to have all its pieces in place. So microdeletion syndromes, as you can hear, there are many, is when you have a loss of part of the chromosome, 5 megabases or less. 5 megabases or less. Meaning very little tiny ones, such that sometimes even tests like karyotype can miss the diagnosis. So there are very small losses of DNA material that is very critical for human life.
And how do these tiny, you've called them very tiny, missing fragments of DNA lead to such big health problems?
Because every piece of that DNA is so important, so critically important. And it's not like each DNA or each gene is in of itself, it works on its own. They are dependent. Everything is interdependent. So it's like a missing link in a tree. It's not a tree if it doesn't have its branches. It's not a tree if it has its branches but lacks the trunk. You understand? So is our human genome. All parts are critically important. And a small, no matter how tiny is missing, even more important. So most microdeletion syndromes are usually on the big chromosomes. Yeah. And whenever they occur, they always affect the most critical part of our body, which is the brain. So what happens is that most of us feel that all CP children are
Cerebral
due to
palsy.
cerebral palsy children are due to a mismanaged delivery. It might not be a mismanaged delivery. It's just that loss of a great critically important part of your DNA.
So we've said there are microdeletion syndromes. So it means there are many. Are there examples that, maybe we've come across? You've given one, like the some cerebral palsy could be.
The presentations of most microdeletion syndromes is cerebral palsy or developmental delay, global developmental delays. A very commonly known microdeletion syndrome is cry-du-chat, 22q deletion. Yeah, it's everybody knew. I mean, they cry like a cat.
They cry like a cat.
Yes. So those are most common, but most of and this is something that's happening in our world of genetics. We are trying to walk away from non-descriptive names. So you'll find If it is a deletion of 7q, we'll say 7q deletion syndrome. If it's a deletion of 11p, we'll say 11p deletion syndrome. We try to describe by naming them. Commonly, most of them will have very interesting dysmorphic features. That is why I always discourage people.
Explain dysmorphic features.
Away from the norm.
Okay.
Like
So they will look different.
Look funny. They call them
funny looking child.
Yes, that funny looking child. And that's why I usually discourage my colleagues. Do not say I saw a child who has Down syndrome. Say you saw a funny looking child because you didn't see the extra 21st chromosome. So they have those dysmorphic features. Those eyes that you're saying they are looking like Down syndrome might be another totally different microdeletion syndrome. So those changes, the facial changes, big ears, their hands are a bit different. All those coming together, and then now you have a diagnosis from molecular cytogenetics, then you are able to give the name of the disease or the syndrome. So clinically, they present as delays. Global developmental delay, gross motor delay, speech delay. Something is delaying this child. And then when you look at them, they are funny looking. So don't give them a name until you
make
test
that diagnosis. So how is this diagnosis made, and at what point is the diagnosis made?
So we should have an idea in utero. We should have an idea
before birth.
The baby is still in the womb. So there's a very critical ultrasound that is done on the 20th week of gestation, and it is called the anomaly scan. I would encourage everybody to have the anomaly scan done in a reputable facility by a doctor. Yeah. And sometimes even go to a fetal maternal specialist to get that done. So there are features that are telltale signs. They can either be nuchal folds, the nasal bridge, the length of the femur, that the heart structure that tells the doctor there's something off. Even the weight of the child, even the way the mother looks like she's
bigger,
but what she's carrying is really teeny tiny. So polyhydramnia. So those things should start telling us there's something off with, as I say, my chromosomes have started misperforming. So that at that time, as early as that, you can prepare the mother psychologically, either to test or prepare her psychologically to know there will be a poor outcome. So once the baby is born, of course, as a pediatrician and a neonatologist, they will come and do the first examination. As they do the first examination, they will be able to pick out some of these changes, things that are away from the norm. And if they're away from the norm, they'll say, okay, there are some dysmorphic features that require further exploration. So it will be at that point that you should be able to diagnose. However, in our health system, sometimes you don't get the luxury of having a pediatrician at birth. So maybe this will be picked up as you go for clinics, that this baby is not growing. Then they make noise at you, aren't you feeding the baby? What's going on? Then when the age mates are sitting down, your baby has not even sat. Then you start asking questions, and unfortunately in our healthcare system, it becomes that proverbial cerebral palsy, and then you keep quiet and move on.
Okay. Is there room to make this diagnosis, or to know even before conception, through genetic counselling, genetic testing, or is it, how do I call it, a random happening?
Sometimes there are two ways. When you're asking the question, I was like, wow, okay. One is a de novo occurrence, where it's a random happening. There's nothing nobody could have done. Nothing can have been told before, heard that these parents are going to have such a child. The one that is preventable, or you can preempt, is when the parents are balanced translocation carriers. Quite a mouthful, eh?
Please explain.
Balanced translocation carrier. Your chromosome is supposed to stack each other in a particular way. They stacked into these nice little snails. Now, in the stacking, they're supposed to be glued together tightly. A balanced translocation carrier is not glued tightly. So the mistakes as the cell divides occurs because they chip away. They
So
don't
instead
move
of
together.
being family fit, they're like trying to balance
Their
and not
balance,
to fall.
not to fall, yeah.
Okay.
So that happens a lot. So if you are a carrier of a balance translocation carrier, you yourself are okay. You have everything in place. Nothing is missing. Even that chromosome in
Then
a
that's
balance,
dancing,
it's just balancing
is
itself.
balancing and staying put.
Yes. However, when you're transmitting to your child, it might be an imbalance, and that balance is lost, and that part is lost totally. And that's how you end up with a microdeletion.
Okay. In Cindy's case, doctors thought it was hydrocephalus. Is there a connection? I know you said, some of the microdeletion affects the brain. Was this part of it, or this was just another addition?
They can present in variable ways. For Cindy, the first thing that was picked up on ultrasound, I believe, was a big head, and it was assumed, because it was a neutral, it was actually assumed to be hydrocephalus, which is a very common occurrence. And of course, care was going to be provided for hydrocephalus.
Yeah.
However, it is also prudent, even when we see that hydrocephalus on ultrasound, to go a step ahead and do an MRI so that you are sure all the structures in and within the brain are in place. So as it turned out later, there are some parts of the brain that were missing. So it's important for us to remember that not all hydrocephalus is because of folic folate. So we need to do a bit more in our health systems for these children who present with hydrocephalus in order to be very clear about our diagnosis. And either way, the clinical profile of a pure hydrocephalus is different from what Cindy proved to be. Because hydrocephalus, very early caught, VP shunt put in place, there should be no concerns. But this time, there were concerns after that.
Yeah. The other symptoms she experienced, like the feeding difficulties, the seizures, the frequent reflux and infections, are this part of how microdeletions show up?
Microdeletions are many and have very little commonality except a developmental delay. For her specifically, a part of her brain had not developed that was involved in coordination. So the coordinating part of it was not working. So she had seizure disorders, and of course, because she couldn't keep things down, they came up and went into the lungs. So most of the time, lung infections and stuff like that. So this is specific for her. We can have another baby who has a microdeletion syndrome that is of 7q. I have a baby with a 7q deletion, and he's different. He just has seizures and nothing else. He feeds very well, he's growing very well, but he's globally delayed. We are on OT, we are trying to get gross motor milestone in place. We have no speech. So you see there's some commonalities, but they're not exactly the same.
Okay. So the delayed milestones cut across. So that should be like the first
the
telltale sign that parents, even healthcare workers, should pick when a child presents. Is there a cure? Of course, like that's one of the questions I'm sure you've come to be asked a lot of times. So is there a cure, or is it just management?
It's management, and it's management right from the word go. The earlier, the better. Yes, you can't change a microdeletion. We can't add the extra that has been lost. Or even sometimes there are also macroduplication syndromes where they have multiplied. You can't change that. But you can manage and get a very good outlook out of it. Yes.
Okay. And what types of care therapies, I know you've talked about OT, occupational therapy, would be most helpful for these children to have, some sense of quality of life?
Yeah. So number one, let's take care of the care provider. Care provider needs a lot of psychosocial support, financial and all other support that you can get. The child cannot stay horizontal all the time. They have to
be upright.
Walk and everything, sit up, everything. These things have to be achieved as early as possible, or within the normal time where we expect babies to sit at around 4 months. We want to see this baby trying to be pushed to that point early. It can be difficult Yeah, and that is why occupational and other adjunct therapies are important, where they bring in support equipment where they strap the baby into an upright position to get her going. You do not have to wait for the convulsion. You can preempt that this baby is going to probably convulse in the near future. Therefore, let's have the neurologist at hand. Let's have screening EEGs from time to time. And if we see something, we have something to give so that now we do not lose, because for every convulsion, you lose something. So we do not want to lose the little gains that we get after a very long time of therapy. So those are the things you should look out for. Of course, feeding is a challenge, and there are enough gastroenterologists around to help us with that and manage. So there's so much that can be done. But all of it is around management and support.
Of course, early intervention in some of these cases and issues that we've talked about is key. In this case, if a couple has a child with a microdeletion syndrome, is there room for genetic counseling, genetic testing for their subsequent pregnancies and children?
And that's the whole point. That's the whole point. And it's about creating awareness that you don't have to do this over and over again. So the first thing is, you have had Cindy, you've had a problem. So let's see, are you a balanced translocation carrier, or was it just an act of nature and you are not the cause of all this? So once we establish that it's a de novo occurrence has a very little recurrence rate. But if it is a balanced translocation carrier, then you know your recurrence rate is very high. Therefore, anytime you're pregnant, we go back to the proverbial NIPT advanced. We are looking at carriosec, all those tests in your pregnancy, even going into the proper IVF formulations, not implantation without checking, but checking before implantation. Yes.
Okay, all right. And looking at our healthcare system, is there more that can be done to either pick up, diagnose, manage, support the caregivers of children with the microdeletions?
So for me, in the area of RAMCA, the ultrasounds, we have to reproductive, maternal health, and
neonatal
yes health. In that reproductive zone, there's a lot of players, and we have to now first of all check the quality of the players in the field. We cannot have a mother. I've had mothers who've had those anomalies scanned done over and over again, and then when they're finally at 36 weeks and they're almost giving birth, the gynecologist does a scan and says everything is wrong. So what was those 12 or so ultrasounds telling them? So we need to look at the players, the care providers. If something is wrong, if something is off, let's say it early, number one. Number two, if you are not qualified to do this ultrasound, don't do it.
Don't do it. Refer to the person.
Just refer to someone else. And let the public, number three, know that there is a very critical ultrasound at 20 weeks. That needs to be done by someone who's qualified. If it's going to cost you 10,000, pay that 10,000. Don't go for the one for 2,000 shillings and then be worried that someone missed something. So that is very key. Once it has happened, as it did for Mama Cindy, once it has happened, as she will tell you, the things that she required to buy, the hospital visits that she required to do,
numerous.
The way her support system was not there. Let's not talk about family. Family is always going to be there. But let's talk about house girls.
Yeah.
If she needed to go somewhere, she couldn't go because there's no help. Nobody is willing. So our system doesn't have a nurse aid support system like maybe from SHA that can at least give Mama Cindy that one afternoon off so that she can go and feel safe wherever she is, that the child is being taken care of. She was 1,000% care provider. She also needed a break.
Yeah.
But where was the break going to come from? You know, we don't have a system that gives them a break. Yeah. Number there's so many 3 or 4. I don't know where I am right now. Costs.
Yeah.
Costs. Supplies. Yeah. She was on a feeding tube. The tubes, the syringes, where were they going to come from? Who's going to buy them? If she's going to be in a hospital setup, of course, they'll be provided. But we have an outpatient coverage that allows you to buy a syringe.
Or that can provide for you.
Or that can provide for you, because I know outpatient coverage will cover you your medication. But now the question is, if she requires outpatient prescription of a syringe, would the insurance pay for that? So there's a lot of things we need to really think about our system, and also how we're preparing her for her next child. Are we ready? Is the system ready for her? Yes. That's why I always tell people, call them by their names. She's Mama Cindy. She can't change, because we have to honor that child.
Okay. So looking forward, or looking ahead, what changes then do we need as a country from us, the consumers of the healthcare system, the providers, and even just looking at government in terms of providing genetic awareness, testing for these rare conditions?
So we've started the conversations. So in conversations, that's when you hear different outlooks and different solutions. So the fact that we have started the conversation, that's a first step. The second step is not keeping it to ourselves. Like I always tell Mama Cindy to always ask people to call her Mama Cindy, so that if there's a question you have to ask, you'll be like, what happened to Cindy? Then she'll tell you. And that keeps on that conversation going. That
Creating awareness.
She continues creating awareness, and she continues to heal. Number 3, I'll stop counting right now, we have to go to primary health. And primary health requires us to do screening. Not only screening the babies, but you also screen your pregnant ladies. In the West, anybody who is expectant after 35 weeks requires an NIPT. A high-risk pregnancy should be screened early, so that now the mother is told, by the way, you're screening, and we start with biochemical screening, quadruple test, and triple serology tests. Once those give us a very high-risk profile, we can already start telling the mother, even before we do this ultrasound, things don't look well, so that she can also start preparing. If they're not looking well, how well is unwell? You understand? So that they can. So the healthcare system first has to be ready to be more preventative than reactive. Currently, we are reactive. Healthcare system.
We are heavy on curative tertiary care more than
the
primary care, or even the rehabilitative care.
And that's the last part, I guess, rehabilitation. These adjunct care providers, physiotherapy, speech therapists, occupational therapists, hydrotherapy, nobody's talking about them. Nobody's singing about them. There are no centers like the way we have Chiromo Lane as a mental health institution, Madare as a mental health institution. We have something like spinal injury that does spinal injuries, that is supposed to be almost our rehab center. But is it really a rehab center for these patients who require other things other than physical therapy? You understand? That's what we need to integrate these things.
Okay. We have a long way to go.
We have a long way to
go, but we have started with the conversations, and hopefully many more Mama Cindy's, Lucy, will come out, talk about their stories, and help create more awareness and push this conversation forward. Thank you, Daktari, for joining us. Thank you for always being gracious with your time to have this conversation on Code of Life through Willow Lifeline Dialogues. Today we've seen how even the smallest changes in our DNA can carry enormous weight for our children, our families, us as caregivers, and our future. If you're a parent, a caregiver, or someone working through the unknowns of a rare condition, know this: you're not alone. The science is evolving, support is growing, and your voice matters. You've been watching or listening to Willow Lifeline Dialogues Code of Life series. If this conversation has helped you in any way, share it with a parent, a colleague, a friend. And for more episodes and content like this, subscribe to our Willow Health Media on YouTube or Spotify and all our social media platforms. I'm Dr. Mercy Korir, and until next time, Keep the conversation going. Stay empowered. Stay healthy.